All right, in this video, I'm going to give you a little brief overview of therapeutic hypothermia, which we generally will use in our post-cardiac arrest patients. Okay, so again, this is mostly used in out-of-hospital cardiac arrest. So we don't tend to use it on patients who've had a cardiac arrest inside of the hospital. We tend to use it for patients who've had an arrest outside the hospital. The research on using it for patients who've arrested in the hospital is not as good, mostly because those folks tend to have a lot more comorbidities, a lot more issues, and it doesn't seem to be quite as effective. But for people who have sudden cardiac arrest outside of a hospital setting, they usually have enough physiological reserve. I'm going to use that term a fair number of times over the course of the semester, but they have enough physiological reserve because they don't have a lot of other comorbid problems that this can be a useful tool for us. All right, so sometimes we will use it in patients that don't meet that out-of-hospital cardiac arrest criteria, but that's based on the clinician's kind of judgment call, right? So what we do is we cool down the patient for about 24 hours after their arrest and the return of spontaneous circulation. All right, so hypothermia should be induced as early as possible to achieve maximum neuroprotection and edema blocking effects. That's cerebral edema. We're really focused on preserving brain function in these patients because remember, if they've suffered a cardiac arrest, the perfusion to their brain tissue has been disrupted for a period of time. And so anytime you have perfusion, especially to brain tissue, anytime you have that perfusion disrupted, there's a risk that of pretty serious neurological anoxic brain injury. And so what we're trying to do with this cooling technique is actually sort of put the brain into more of a dormant state. So the neuroprotection that is offered by therapeutic hypothermia has really been attributed to reducing that cerebral brain metabolic demand, decreasing the rate of oxygen consumption, and reducing the ATP. Remember, that's the energy compound in the cells, the ATP demand. So it's all about reducing cerebral metabolic demand. And that gives the brain tissue some time to recover from the lack of perfusion, the assault to that tissue. All right, so what happens is it also decreases mortality overall. So we don't understand all the mechanisms to this, but patients are more likely to have a positive outcome overall if we're able to initiate therapeutic hypothermia. All right, so it happens in 3 stages. The first would be induction, where we start that cooling process. Then we have a maintenance phase where we keep the patient cooled in a pretty tight temperature range for a period of time. And then we have a rewarming phase where we rewarm the patient back up to normal body temperature slowly. We don't want to do it fast because if you rewarm like instantly or really fast, you actually lose all the benefit that you might have gained from that period of hypothermia. So our goal temperature is anywhere between 89.6 and 96.8 degrees Fahrenheit. Now that might change or vary depending on the clinical practice setting. Different protocols will call for different temperature ranges. Some are much tighter than others, but essentially we do try to keep the temperature in that fairly cool range. So how do we do that? Well, we use usually more than one technique. Sometimes we'll infuse cold saline. Sometimes we'll put what's called a cooling catheter in, usually inserted in the femoral artery. We also might use cooling blankets or a device like it's shown in this picture that cools particular areas of the body by circulating cold water through these pads. Or we might just apply ice packs, especially to particular areas like under the arms, the carotids especially, because the carotids are the main arteries that feed blood to the brain. So if we're cooling right there on the carotids, it's going to improve that neurological preservation. All right, so we also have to keep patients intubated during this process and sedated, and we'll usually give them neuromuscular blocking agents as well. They are heavily monitored cardiovascular-wise. We give them neuromuscular agents to block shivering and also to make heat exchange more efficient. So those blocking agents work really well against that shivering. The reason we don't want patients to shiver, right, is that's an adaptive mechanism. When you're cold, normally, you shiver, and that helps your body warm up, right, because of that muscle action. So we're trying to prevent that from happening because we don't want the patient to warm up. We want them to stay cold. So we will give meperidine, sometimes clonidine, doxapram. Those are the most effective drugs used to suppress shivering. And also one benefit is they don't have as significant respiratory depression effects. So I'll say those again. Meperidine, clonidine, and doxapram are the most commonly used neuromuscular blocking agents during therapeutic hypothermia. So the last piece here is I have a clinician who's going to talk about therapeutic hypothermia and how they use it in their particular hospital.